You have the presentation? There we go. Great. Well, it's my pleasure to join this panel, try to be brief. One of the elements of our mission as director of the National Heart, Lung, and Blood Institute is to really have a portfolio of programs that fundamentally involves investigator-initiated discovery science that draws upon the collective intelligence of all the domain experts across a variety of disciplines to advance the prevention and treatment of heart disease. A critical part of that is to have a portfolio that spans the full spectrum of this biomedical research, beginning in discovery science, in which understanding the fundamentals of how the heart works, its electrical system, in health, and can inform how it goes awry in disease and can cause dysrhythmias and death. Similarly, translating that discovery science into humans and appreciating different pathobiologies and systems. And so now understanding, for example, the molecular basis of some of these arrhythmias, understanding the channels that have heritable mutations that may predispose to cardiac arrhythmias and death has been a major advance that's been made over the last couple of decades. And then translating that into advances in treatment strategies. As part of this spectrum, as we learn pathobiology, we're able to more effectively intervene in ways to change the natural history of the disease. An important element of this model that you'll notice here out on the right-hand side is to not only prove efficacy of new treatments, whether it's how to intervene in new CPR methods or resuscitation efforts, but also to be sure that we go that final leg of the journey to ensure that what we know is what we do and its practice in real-world context in communities, such that the discovery science indeed has an impact on the health of the nation and really is part of fulfilling our mission. And I think that's where having this broad portfolio is critical to our success. We are excited about the opportunities that are emerging, in which we're becoming more aware of the underpinnings of heart disease and sudden cardiac arrest and death, in part related to advances in many of the technologies and tools to understand pathobiology in humans, whether it is in appreciation of the molecular basis revealed by omics. We now have the capability to sequence an entire human genome in a matter of days. And again, layers of its proteome and epigenome and other forms of deep characterization of the molecules that underlie the heart and its systems. Similarly, we've already had discussions about the wash of data, big data that is emerging, in which you have in your pocket one of the most advanced computers that we couldn't even imagine when I was in medical school, but it is able to match my heart rate. You can see I have a little wrist band on that is counting my steps, can estimate my calories, can tell me about my sleep-wake cycle. And we're at an age of developing of sensor technologies that are telling us more and more about our body's physiology. I think this is part of what's on the horizon as we look at understanding what might be preceding and antedating that sudden arrival in the emergency room. Up in the upper left-hand corner, we now know that we can take a piece of your skin and with technologies, turn those into inducible pluripotent stem cells that can be differentiated into various cell types and indeed can be produced in the cardiac myocytes that then can beat in a dish and study the electrical systems of your particular skin cells, and indeed take that skin cell from patients who may have one of those heritable syndromes that predisposes to cardiac death, understand what drugs might manipulate that electrical system, and understand what are the factors that might trigger it, a fatal arrhythmia. These are the technologies and tools that are emerging that gives us a lot of excitement about advances that we can make over the next 5 to 10 years. Indeed, NHLBI is building on a legacy of a research portfolio that's already begun to make some of these contributions. Indeed, practice changing trials that are being done in our various research networks that are refining what resuscitation science is and does and how it can influence patient care. We're delighted by a new effort, in part related to the leadership of Dr. Jeremy Brown in the Office of Emergency Medicine Care Research, in which collaboration between NHLBI, NINDS, DOD, and others is bringing together a collaborative network in which we can continue to pursue advances in emergency care clinical trials as just one example of how we intend to continue to push the research agenda in ways that ask compelling questions that will have public health impact and improve health outcomes in this space. We are engaged at the NIH with all our circle of partners. We can't do this alone. We depend upon ideas coming from investigator-initiated research from the scientific community, as well as patients, professional organizations, and nonprofit organizations like the American Heart Association in bringing together a collective agenda that we write together. Indeed, we are at the final stages of our strategic visioning process in which we literally use crowdsourcing to solicit input and ideas from a variety of stakeholders to help us set an agenda for the next 5 to 10 years, of which indeed this topic is one in which a number of compelling questions and critical challenges emerged from the community that will direct our efforts. Intriguingly, many related to optimizing the diagnostic and therapeutic strategies to prevent, treat disorders like sudden cardiac death, and to translate clinical efficacy findings for public health impact that are effective. And this implementation science space is an area of particular importance that we think as an element of our portfolio where we again transition from discovery to knowing what is efficacious to then developing effective strategies that have impact in communities throughout our country. And indeed, we're also encouraged and excited by the promise of precision medicine as a particular opportunity. The NHLBI has a program called TOPMed, Transomics for Preventive Medicine and Precision Medicine, in which we're using these omic tools in the NHLBI cohort studies, Women's Health Initiative, the iconic Framingham Heart Study, and others, where we have hundreds of thousands of individuals who are deeply phenotyped, and we're now overlaying the new omic technologies. We're also excited about what's emerging in the President's Precision Medicine Initiative that we think complements this effort, in which NIH is embarking literally within the last few weeks in rolling out a number of elements, including a cohort that we hope to reach over 1 million participants, in which the participant and the citizens of this country will be central to the process, that indeed generating their data and sharing their data, the development of standards and interoperability that leverage electronic health records in health systems around the country, tools that indeed engage in that sensor technology and mobile health as an integrated element toward a national learning health system in which this data can come together in ways that we can predict and prevent and treat disease much more effectively in the digital age. And so we hope that we can fulfill a vision in which we can uncover what happened in the 24 hours preceding a cardiac arrest by downloading continuous cardiac monitoring that may be part of the new age of sensor technology, where, again, this technology could be used to engage those who are CPR trained within a minute or two of someone who goes down and is called into 911, where indeed locating that AED may be facilitated, again, by digital-to-digital communication. These are the opportunities that we hope and envision that we can bring to reality. So just to close, there are some questions and considerations that I hope that this group will wrestle with and hopefully give recommendations on. One of which is to provide us with further guidance on what you think are the most compelling scientific questions to address in preclinical models and clinical trials to most significantly improve morbidity and mortality related to sudden cardiac arrest and death. Similarly, what are the opportunities to leverage mobile health data science and the promise of precision medicine to further understand the subphenotypes of resilience, those who may have predisposition in a channelopathy but never seem to develop the arrhythmias and certainly don't proceed all the way to death, as well as those indeed who are more susceptible. What are the elements that distinguish these two different outcomes? And then finally, what strategies should be tested in a rigorous way that leverage existing health systems that help us to really transcend these siloed data sets to really look at their interoperability and indeed make syntheses of data and patterns so that we can increase the adoption of effective and implementable practice to actually reduce and preempt sudden cardiac arrest and death. I think these are some of the opportunities that are on the horizon, and we look forward to this dialogue to further guide our agenda as we move forward. Thank you for your attention.